very interesting to talk to you about the transitional care for diabetes, because here the internists and also the pediatricians, we are all sitting together and then agreeing on how to control diabetes in this critical age period. Who sees diabetes in adolescence? So all of us, okay. So that's very interesting. Then I will speak about what are the challenges of management of diabetes in this age period, whether for the diabetics, for the physicians, we the pediatricians or you the internist, and for healthcare providers who are responsible for the policy making. And then if we want to establish transitional clinics for diabetes, how to do that? So that transition period, it's a gap between childhood and adulthood. So we're now speaking about how to bridge this gap between the pediatric and the adult medicine for patients with diabetes. So let me tell you the story of one of our patients, Amira. She's a 15 years old girl that presented to one of the pediatric diabetes units, by DKA. She was diagnosed as type 1 diabetes at the age of 4 years, has been on basal bolus insulin therapy, and was following up regularly with her parents, and she had a mean hemoglobin A1C of 7%, no chronic complications. She's doing the regular screening till the age of 12. Then what happened? At the age of 12, she began to refuse to come to the clinic and be encountered with the young children. Besides, she began to refuse any form of parental supervision. The parents used to come alone to the clinic so that they would take our advice, and then she was told that because she's 12 years old, she has to be referred to an adult diabetes center according to the administrative hospital regulations. Her parents mentioned that the adult center shifted the regimen to mixed insulin twice per day, as this is the protocol with the adult diabetics needing insulin, and because the insulin was provided by the insurance and it is cheap. The parents said that Amira started to stop doing the self-blood glucose monitoring because she found the adult diabetics not doing it. On revising the data and the labs, she was found to have uncontrolled diabetes for the past 3 years. Hemoglobin A1C started to rise and it began to be around 10%, and her insulin dose increased to more than 2 units per kg per day. And screening in the previous 2 years revealed persistent microalbuminuria and dyslipidemia. Background retinopathy, carotid intima media thickness increased. She has lately been non-compliant as regards the insulin therapy and the dietary regimen. She became stubborn, aggressive, suffered psychological depression, refusing all forms of parental supervision. Coming from a rural area, she was going to be forced to marry within 4 months, and that made her very upset. The parents discovered that in her room there is a box of tranquilizer tablets. She started skipping the insulin injection several times and had recurrent hypoglycemic episodes and fell down in the street on her way back from school, and her mates brought her home. The parents mentioned that Amira felt lost in the adult care system, and the parents could not follow what's going on because they were not allowed to be involved as they used to be in the pediatric diabetes units. The parents preferred this time to get Amira in DKA to the original pediatric diabetes center because it was the original place, knowing her medical history. So Amira is the typical child in the transition period. Many bumps on the road. So, the age of adolescence, there are a lot of changes, not only physical and biological, also mental, psychological, social, and cultural. And these are the day-to-day challenges for our diabetic children. They have to take multiple daily insulin injections, frequent pricking by self-blood glucose monitoring, dietary restrictions, They are enforced to do lifestyle modifications, and they are afraid of the acute and the chronic complications. Besides, there are extra challenges in the transition period because this patient is not a child anymore and not yet an adult, something in between. We did a survey in Cairo University interviewing diabetics over the age of 12 years and their parents. We studied about the files, and we found that 40% are over 12 years, but they started to have loss of follow-up. In this age group, they don't come anymore. The parents, maybe they are coming alone to take their advice. There is non-compliance of the children in 60%. There is refusal of parental supervision in 80%. They hate to be encountered and examined with the young kids in 60% of the cases, and sometimes in 40% of the cases, even the parents lose motivation and they do not come anymore. The hemoglobin A1C mean is about 11% in this age group, and the prevalence of recurrent DKA is about 25%, and the complicated cases of DKA are about 70%. But of course, there are administrative problems for admission. When these children come to the pediatric units, they are told they are about 12 and they cannot be admitted, and they are lost in the system. The prevalence of recurrent hypoglycemia is about 30%, and these also on the slide, the prevalence of different chronic complications. You see between 30 up to 60% of the chronic complications because of the bad compliance in this age group. So these patients actually prefer the pediatric care, yes, because they are accustomed to the pediatric care, but they do not like to be encountered with children. They prefer to be encountered away from their parents. They are non-compliant to the insulin therapy and to the healthy dietary recommendations. And there is an administrative difficulty to offer funds, charity, financial support, medications, or to write formal reports because they are in between. They are not related to the pediatrics, and also they are not related to the adults. So they are actually lost in the system. Of course, the incidence of type 1 diabetes is 8 per 100,000 and it's rising. And also we have rising incidence of type 2 diabetes. There is a pandemic of type 2 diabetes, and you see here Egypt has a high prevalence of obesity and high risk of type 2 diabetes. And this is a global survey that has been done in adolescents in Egypt between 2006 and 2011. And you see here that overweight and obesity in our community is about 30%. It's just the same like all over the world. 1 in every 3 adolescents that you encounter is either overweight or obese. And these are the risk factors also in Egyptian studies of hypertension, prediabetes, dyslipidemia, and all the components of the metabolic syndrome. So we have a real risk even for type 2 diabetes in our population. And in a study done in 2011 found that the incidence or the prevalence of prediabetes in adolescent Egyptians are about 16%, while the incidence and prevalence of diabetes is about 0.7%. Moreover, the incidence of type 1 diabetes is increasing all over the world. So we are handing more pediatric population to you, the adult diabetologists. So we have to get prepared about the challenges in this age period. First, there are differences between the pediatric and adult care that have to be cared about. There is a poorer glycemic control in this age group. There is accelerated development of chronic complications in this age. There is higher incidence of acute complications, of psychosocial disturbances. In our community, especially in the rural areas, they get married so early, so we may have reproductive health issues. Also, there is substance use and abuse, although there is a taboo about talking about it, the smoking and also the drugs in the community. And of course, there is loss of the follow-up care. So concerning when the patients come to us in the pediatric care, they come with the family. It's a family managed care. But when the adult diabetic comes to you as internist, it's a self-care. He's an independent person. But in adolescence, it's a shared care. It is supervised by the family, but these children feel that they are independent. You see, this is our diabetes education team in Dempo, Cairo University, and you see how the parents are sitting with their children, taking the education about everything concerning the diabetes. Adolescents refuse to sit with their parents, and they want to be managed separately. So there is a need to have transition clinics, because adolescents should be central in communication, with discussions focused on him or her. They should be offered time alone with the clinician. They should have confidentiality and privacy. And the discussion with them should be interactive rather than interrogative. You have to listen carefully to these children in this age group and to respect their concerns and their points of view. And also there is a big difference concerning the healthcare providers. In pediatrics, the majority of pediatric patients are seen by endocrinologists, but in adult care, it is mostly seen by primary care providers. So there should be a more gradual transition, and it is preferable for these children. So what are the cutoff limits? If you want to do like transition clinics, what is the cutoff limit of the age to start this transfer of care? Actually, the ISPAC guidelines 2018 says there is no universal cutoff limit. It says that recognize that young people have differing views on the appropriate age of transfer of the care to the young adult service. So there should be a planned, coordinated transition to the adult care. The pediatricians sit with the internist to provide for every individual in the most appropriate time for him or her. If we see Europe, we find that transition occurs at 18 years to 22 years. In Canada, it's around 18 years. In Egypt, as I told you, there is some isolation. The pediatrics till 12 and the adults from 18. So there is a gap in between that is not managed properly. But what about the recent guidelines? The recent guidelines says that the transition should start at the age of 12 to allow sufficient time to adequately prepare the patients, the families, the medical providers before they are already 18 and they are transferred to the adult care. So the transition clinics have to be done conjointly, pediatricians with internists. This age group has poor glycemic control because of the endocrine changes that occurs during this age period because of the increased insulin resistance, the erratic meal and exercise patterns, the poor adherence to the treatment regimens, the prevalence of eating disorders, the hazardous and the risk-taking behaviors, and the increase in the weight gain, especially in females. And it's already known the relation of diabetes with the insulin resistance, and all the studies have documented increased incidence of fatty liver among obese children with insulin resistance. 32% of youth with type 1 diabetes have hemoglobin A1C above the targets. They are non-compliant and they do not meet the targets. And a great proportion of those who are in poor glycemic control are already teenagers. 1 in every 4 patients aged more than 12 years have hemoglobin A1C more than 9.5. And this is a Cochrane systematic review which I have done in the Cochrane, documenting the value of adding metformin to insulin therapy to overcome the insulin resistance in this age group. Third, there is accelerated development of chronic complications in this age group, increased prevalence of the cardiovascular risk factors, microalbuminuria, neuropathy. So there has to be focus on the screening for the micro and the macrovascular complications in this age period. There is also a high incidence of acute complications with DKA, and in countries who have implemented the transition care programs have found a tremendous decline, as you see on the right from the left, of the incidence of diabetic ketoacidosis, and also in the mean length of the stay in the hospital markedly improves if they apply the transitional care for the diabetics. There is also a problem in this age group. There is early loss of the glucagon response, and there is high incidence of hypoglycemia Oh, so the time out.
2 more minutes?
So actually, it's very important that we work together, pediatricians and internists, to establish transition care. But this has to be supported by the system, by the authorities, by the health systems, because
IT.
it needs a collaborative care between both groups. There has to be like good registration. There has to be preparation and planning of the teams to work together, okay? So this is the incidence of hypoglycemia that I said, and there is a high incidence of the psychosocial problems, anxiety disorders, depression, the reproductive health issues, as I told you, has to be, so there has to be a multidisciplinary approach. There has to be awareness about the substance abuse and the use and the smoking, because it's very prevalent in our community now, to decrease the incidence of the loss of the follow-up care and to do the education and the nutritional management to appropriately manage the weight in this age period, because eating well while eating right is half of the fight. It's also important to do health awareness for the healthy lifestyle for these obese. So how would a transition plan look like? As I said, is it pediatrics and adults all alone? Or is it that they stay with the pediatric system? No, the ideal is that there should be a transition clinic in between pediatric and adult care. But how to do that? We have to work together to establish clinical policies. We should have good registries for the patient in order that they are transferred safely from the pediatric to the adult care. We have to prepare the teams that will care for these children. We have to plan very well for every individual the appropriate time for the transfer so that it is gradual, and we should get the institution and system support. So the take-home message, we should put the light on the 8 areas of challenges in the transition period. We should work on them, and we should form multidisciplinary diabetic teams composed of the diabetologist, the pediatrician, the internist, the family medicine, the nutritionist, the dietitian, the psychologist, and other healthcare professionals. We have also to train our paramedical personnel to do the role of the diabetes educare. So let's work together for effective transition care, because optimal health care is achieved when every person at every age receives health care that is medically and developmentally appropriate. Thank you very much, and greetings from our military high leaders.